Hello everyone, this is Dr. Rajiv by your side. I'm a resident cardiovascular surgeon and we're going to be looking at a report of mine on eversion carotid endarterectomy with conduction anesthesia using ultrasound. It's a very common vascular surgery that comes into daily practice and I've already participated in more than 300 surgery of this kind in 1 year, and you can see me here just mobilizing the carotid artery. Now, with this PPT, the objective is that once we end, you are well versed with what the surgery is, what are the kinds of surgery, what are the two types, why we prefer local anesthesia or regional anesthesia, and what we see in ultrasound, what is Doppler, Shunt, and a wake test. So I'm sure you're going to like it, and I hope that you like it. So let's get started. So first of all, what are the indication of the surgery? First of all, symptomatic patients with more than 70% stenosis of the carotid artery, especially the ICA, internal carotid artery. And if it's already 100% occluded, so 100% is called occlusion, CTO. It's not stenosis anymore. Then we don't touch the artery. Okay, so if you get a patient with 100% occlusion, then CTO, then you don't go for this surgery. It's only 85, 90%, 75%, more than 70%. And in asymptomatic patients with stenosis more than 70%, if the preoperative risk is acceptable. Next, a little bit about what we do and how we approach. To mark the region, what we do is from the angle of mandible to the sternal head. This is where you have to give the incision and approach from the skin to the platysma and then the cervical fascia and all. And what nerves are there? That is 9th, 10th, 11th, and 12th, and also ansa cervicalis from the cervical plexus. Now, vagus and hypoglossal are most commonly encountered because spinal accessory and glossopharyngeal, they are a little up. So they don't usually come into acquaintance. But yes, if the BCA, brachiocephalic artery glomus, is a little higher in some patients, that is a little weird anatomy, then you can also encounter glossopharyngeal and spinal accessory. So this is going to be the line of incision, you see, from the angle of mandible to the sternal head. Next, what are the two kinds of surgery? One is conventional carotid endarterectomy, where you go straight. This is the line of incision, and you extirpate the plaque and just close it, but with a patch. You need a patch here. But the pros about it is that you can also do a shunting if needed. And eversion carotid endarterectomy is where you give an oblique incision that you see. This is the line of division with the ICA. Okay, now how you will understand which one is the internal carotid artery and which one is the external carotid artery here is that external carotid artery only gives the branches in the neck. ICA does not give it. So you can be very sure if there are branches, that is the external carotid artery, ECA. And with no branches, you go ahead, you proceed and give a line of incision over here. And then you clamp and extirpate the plaque and remove the atheroma and close it with anastomosis. You can use a parachute technique. And the benefit over here is you don't need to use a patch. But the difficulty sometimes for young surgeons can be if the length of the plaque is too much, it's difficult to everse it out and remove it. Eversion, that means to fold it, backwards and remove the plaque. So you get it, right? Eversion carotid endarterectomy nowadays is very popular, and we almost use eversion carotid endarterectomy only. So I've tried to show you here what we do actually, right? So now it's very important to continuously monitor because it's one of the main arteries supplying to the brain as well. So cerebral perfusion monitoring, in this we usually do a transcranial Doppler to check for cerebral ischemia if there are not. We also do a carotid stump pressure to check the back pressure from the circle of Willis, and if the pressure is less than 50 millimeters of mercury, that shows hypoperfusion. But one more thing that we do nowadays is we do a transcranial cerebral oximeter. So we put two patches over here, and with the dural venous sinuses, it constantly shows during the surgery what is the oxygen perfusion rate. Just like we have SpO2, it shows the transcranial oxygen perfusion ratio. So, and also after the clamping, it should not go more than 20% down. Okay, if it is happening, that means the risk for neurological deficit is higher, and then you have to intubate the patient and go for a general anesthesia. This is a report of the original investigation for the detection of brain ischemia, which is achievable with regional anesthesia, and a combination of stump pressure and either TCD or EEG appears to give the best results. Now, EEG, I never use it, but I told you cerebral oximeter and transcranial cerebral oximeter and Doppler study is what we use. So you get the idea about the surgery. What we do is we give an incision over here, platysma, we mobilize the carotid artery, the glomus of the carotid artery, the common carotid artery, internal carotid artery, external carotid artery. We give an oblique incision to the internal carotid artery. We extirpate the plaque. We close it. We anastomose it, and we wait for hemostasis. We check if there's no problem. We also do an awake test, which I'm going to be talking to you about later in the presentation. And then we close. What we do is we stitch the platysma, and then we do a cosmetic suture, which is a transdermal suture. So it is very beautiful, and the patient is in the ICU for 1 day. We also put a drainage so that there is no hematoma or post-operative risk of hematoma. And also after 3 days, you can discharge the patient. That is a very good benefit of eversion carotid endarterectomy. Now, anesthetic management, there are three kinds of anesthesia that we usually prefer in this surgery. One is general anesthesia, which I don't prefer usually. But if the patient is like, a risky patient, then we go for general anesthesia. Local anesthesia and regional anesthesia are the ones we use lately, and combined is general anesthesia with a superficial cervical plexus block and clonidine, which gives the best hemodynamic stability. This is also what we use. Now, anesthetic management, the goals are for awake test, neurological evaluation, ablation stimulatory, and also stress response to surgery, and to maintain hemodynamic stability. Now, advantages to LA is awake neurological testing. What you do is we give a ball in the contralateral hand. For example, if the left carotid artery is performing the operation, then we give a ball in the right hand, right arm. And once we clamp and we have occluded the blood supply, what we do is we ask, to press the ball or squeeze the ball twice. So we check for the motor response, okay, if it is working. And then we also ask him to say something like, 333, 333, or 333, or what is your name, or, count from 1 to 10, 1 to 10 twice. So this is awake test. So, and also we check for the pupillary reflexes. So EVM for the Glasgow Coma Scale, we just check it. And if it is normal, we just proceed. And if it is not, we intubate the patient and we perform the surgery in general anesthesia. Next thing is a little brief what you'll look in the ultrasound when you're going to perform the local anesthesia or the regional anesthesia. On the top, you will see sternocleidomastoid muscle. This is the internal jugular vein, which gives a branch that is facial vein. Now, facial vein is the most important landmark when you are going for the surgery. So facial vein lies like this, and then here is the carotid artery. So facial vein is above the carotid artery. So you have to, cut the facial vein and then ligate it, and then reach the common carotid artery. So you can see the facial vein over here, and down below you have the carotid artery, common carotid artery. This is the vagus nerve. This is the thyroid. All right. Now, regional anesthesia, what we do is superficial and deep cervical plexus, we go for it. You can see the great auricular nerve, and also C2, C4 dermatomes. We go for that. Now, technique of RA is for a superficial cervical plexus block. What you do over here, you see in the 3 angles you have to go. So there is a superficial cervical plexus, you can see, and this is the sternocleidomastoid muscle. So first you numb the muscle, you go in regions, you numb the platysma, and also for placing the drainage. So you have to go for a little longer length because the drainage is going to be here. So you also have to, numb the skin for a big length. And then the platysma, sternocleidomastoid muscle, which is also called, the platysma is also called the shaving muscle because it's on the top. So complications for this can be intravascular injection, recurrent nerve palsy, partial brachial plexus block. And also sometimes the patient complains, I can't feel my teeth, I can't feel my tongue, but that is normal. It comes back after 3 to 4 hours. Now, technique of it is deep cervical plexus block. What you do is, you see, I told you in the 3, always you have to go in 3 regions. You have to put in the C2, C3, and C4 dermatomes. Okay. Also, you can do a vagus block, but vagus block can also be a complication sometimes. So it's on the proficiency and professionalism of the anesthesiologist and the radiologist how they decide usually. And that is why as surgeon I sometimes feel safer because this is what is a very crucial task as well, and that is why surgery is always a teamwork. Also, talking to you about shunting. During the operation, a shunt may be inserted, and also during Steele syndrome. In Steele syndrome, what happens is the vertebral artery, the first part of the artery from the carotid plexus and the other parts is occluded. So what you do is you put a shunt sometimes. Now this shunt is different. For Steele syndrome, the shunt is different. I will talk to you about Steele syndrome later because now it would get like too much. It's also a very interesting topic, Steele syndrome. But now this shunting is, for during the operation, to maintain the blood flow, what you do is you place the shunt, you can see between the common carotid artery and the external carotid artery. And here where you have placed the clamp, right? Or above the internal carotid artery, you can place the shunt so that the blood flow is restored and no problem at all. But usually we don't do it because it can cause a lot of complications because the layer is very thin. The vascular walls are very thin and we don't want to mess with it. So it can cause carotid dissections, it can cause the tunica intima layer tears, or also it can cause air embolism. So to avoid that, we don't do shunting these days, but for Steele syndrome, shunting is a must. Now, what are the post-operative conditions and what you need to do? Wound hematoma. So for hematoma, we usually place a drainage, I told you, and every 30 minutes you have to check for the drainage. If it is full, if it is more than 20 ml, it's risky every time. If it is coming out more than 20 milliliters every 30 minutes, then you have to put an ice, you have to go for cold compression, and you have to check for hematoma. And continuously after 30 minutes, every 30 minutes, you have to monitor. And in the ICU, you can also, then advise for a cold compress, and usually it does not occur. Also, post-operative stroke is a very common complication. It's not a very common as in it's a very common dangerous complication. So a stroke can happen, nerve damage can happen. So usually some people due to damage to the recurrent laryngeal nerve lose their voice for some time, for 2-3 months as well. Hypertension or hypotension and carotid body denervation can happen, and blunting of ventilatory response to hypoxemia. This is also very common, and that is what you have to monitor using the transcranial oximetry. And embolism, it's mostly when you're shunting the patient, and MI. So I hope you understood everything about it. I'm thankful and grateful for your precious time. And I love you all. Love, love. See you again. I hope you enjoyed. Bye bye.